Welcome everyone. Welcome to the Anova Peterson Life with Cancer Women's Sexual Health Series. We're so excited. Today is night number 6 in a series of 11 here. My name is Rebecca DePatri. I'm one of the oncology nurse navigators here at Anova Life with Cancer, and I'm specializing in sexual health. I work along with my colleague Lauren Broshak and Jennifer Byers to sort of help get this series going. And I'm really excited to be with you tonight. And before we get started, I just wanted to get a little background information on our program and what to expect tonight. First of all, a big thank you. We are so grateful to the Cancer Action Coalition of Virginia and the CDC for giving us this grant to be able to support this program. So really appreciative of that. If you've attended some of our series already so far, I guess I can just skip to the next one here. We have some awesome speakers, just really amazing that we're able to have all these experts come in and talk. Tonight, we have Dr. Shawn Davis-Wilensky giving us an overview of women's sexual health after a cancer diagnosis. We'll continue on all the way through June, discussing a variety of topics: managing emotional distress, finding pleasure in toys, treating sexual health concerns during and after cancer diagnosis, psychosocial adjustment, and sexual desire. So some awesome topics with some incredible experts. So I welcome you to attend all of these programs. And remember, they're all recorded and will be available usually within a week on our Life with Cancer YouTube channel. If you're part of our system, you know about us, hopefully. But if you're from other systems or from other places in the country or the world tuning in, just a little bit about us. We are Anova Peterson Life with Cancer. We are part of the Anova Shar Cancer Program. We are really unique because we're able to provide education and psychosocial support to anybody impacted by cancer, from diagnosis to survivorship. And we do this through evidence-based and holistic care. We don't charge for our services, and we support anyone no matter where treatment is received. Our mission, bottom line, is to enhance the quality of life of those affected and impacted by cancer by providing evidence-based education, support, wellness programs, and integrative therapies, and programs like this tonight. We offer several different groups and programs: educational programs, mindfulness programs, fitness, and a whole lot of additional things. This sexual health programming is in addition to our sexual health support group that we offer monthly called Get Your Groove Back, and some pelvic floor health movement classes that are newer this year and offered at Life with Cancer. Additionally, Anova Shar Cancer has a specialty shop. Sometimes in some of our programs here, we're talking about items that you may not know where to get. Know that you can purchase them in the privacy of our cancer center here. It's a beautiful shop. Run by an incredible person in the shop. You can email them, you can reach out to them, and all the things that we're talking about tonight can be purchased through them as well. They can be sent and picked up at the specialty shop or mailed in privacy to your house. Just logistics for tonight. We have a chat and a Q&A. Please feel free to put any questions you might have or comments, or connect with one another in those settings. I will read all the questions to Dr. Davis-Wilensky at the end of the program for her to answer. If you would like to chat and connect with others, if she has questions and Dr. Wilensky is looking for some input, feel free to put it in there. That part is not recorded or will not be put up on our YouTube channel, just the video of this education program. For some who may be registered under their iPhone or iPad, if you can, please rename yourself. So that helps me with registration and checking you in, and also gives Dr. Davis-Wilensky and others just an opportunity to be able to connect you if you have a question. Please feel free to just put your first name and last initial if you're comfortable with that. Our legal disclaimer, we do want to make note that this class is for informational purposes only. And if you have a specific question, to really direct them to your oncology provider. Don't take the information tonight as medical advice. certainly we're there to answer questions, to give you information to bring back to your provider. And we hope you pick something up from this program you didn't know before, and just continue to build your knowledge around sexual health. I'll stop sharing here. And with that, I'd just like to introduce Dr. Shawn Davis-Wilensky. She's a specialty care physician board certified in obstetrics and gynecology, and a certified menopause practitioner. She joined us here at the Inova Seville Cancer Screening and Prevention Center in 2023 and has been in practice since 2003. Her clinical and research areas of interest include how society addresses the healthcare needs of women across the lifespan, and she's focused on decreasing alarming disparities in outcomes between groups. Dr. Davis-Wilensky is focused on addressing healthcare needs of women at high risk for cancer. She provides gynecological care to women whose lives have been affected by an increased risk for cancer, as well as those who've undergone a cancer diagnosis. Her position here allows her to expand cancer screening and to engage groups that are currently underrepresented in research pools, are diagnosed later, and may have a higher mortality and morbidity rate. Most recently, Dr. Davis-Wilensky is piloting a multidisciplinary sexual wellness group for women affected by cancer. All of this is in part to improve the well-being of women as we develop healthcare centers that need to meet these needs and aspire to partner with them in optimizing their health. Dr. Davis-Wilensky graduated from Harvard College, Johns Hopkins Bloomberg School for Public Health, and Georgetown School of Medicine. She and her husband, Peter, are parents of 3 daughters, and she's resided in the DC area for over 20 years. So with that, I'd like to pass to Dr. Davis-Wilensky, and thank you so much for being here and participating in this awesome program.
Thank you, Rebecca, and thank you each of you for coming tonight. I'm going to share my screen. Rebecca, is that looking okay? All right, so tonight it's a little bit different from the other nights because we are going to be talking more of an overview of the women's sexual health after a cancer diagnosis. And each of the other parts of the series, you'll get to really dig in to each of these areas. But hopefully you'll hear something here tonight that brings you back on one of the other nights so that you can hear the wonderful providers who are here to share their knowledge. My name is Shawn Davis-Wilensky. I really do go by Davis. I'm a gynecologist at the Seville Center for Cancer Screening and Prevention. And I have no disclosures tonight. The reason we're talking about this is because cancer and its treatment can significantly impact sexual wellness for women. It affects those currently fighting as well as survivors of cancers. But unfortunately, it's not often addressed by medical professionals. Even though about as high as 90% of women with diagnoses of gynecologic cancers, that's cervical, uterine, ovarian, have some form of sexual dysfunction. About 70% of women who are diagnosed with breast cancer also report sexual dysfunction. But we often miss that there are women who don't have GYN cancers or breast cancer, but still suffer from sexual dysfunction. And this number is somewhere between 30 and 50%. And there are various cancer treatments, the radiation, chemotherapy, surgery, all the adjuvant treatments that still impact a woman's sexual health. And fortuitously, I guess is one way you could say it, I was just looking through Reddit and I noticed that there was this question put forth by a young man who said, his wife was diagnosed with a pretty aggressive form of breast cancer, and she did her chemo and mastectomy, and the good news is that she did great. But being 41, this really impacted her sexual wellness. He said they were having sex pretty regularly, 3 to 4 times a week, even with children. But now it's impossible. And she is obviously very upset. She describes things like it's as dry as the Sahara Desert, that when they try penetrating sex, it burns like a million fires. So of course he's saying, I'm not engaging because he doesn't want to hurt her, but he understands that she is just devastated by this and she doesn't feel, quote, like a woman anymore. And so he's looking for advice on this. And I think this really brings home very quickly and very clearly the both psychosocial model that talks about how the female sexual dysfunction and how cancer impacts that. Physiologically, all of the different parts, the fatigue, the medications, the urogenital disorders, the emotional parts of this, the anxiety, the stress, the concerns about self-image, depression, and then the interpersonal relationships that one has with your partner, as well as kind of the influence of society, how we talk about sex, concerns about religion, and then like personal family taboos about sex really impact how a woman walks through this journey. The range of sexual dysfunction among cancer survivors is pretty high. About 70% of women with cancer reported some sexual dysfunction. But I think the thing that really strikes me here is the significant embarrassment that many women have about their problems. And furthermore, the impression that nothing can be done, which the embarrassment plus the sense that nothing can be done basically means they don't seek these things. And assistance with these things. And I think we as providers, sometimes because we feel nothing can be done safely, and we feel out of water and out of our space, that we are nervous to bring these things up. I think just now menopause like things are becoming kind of sexy in this country, and therefore which then lends itself to this space of where women are dealing with cancer and some of those issues of menopause like symptoms are happening. And this allows us to finally start to really pay attention to the fact that we are so happy that people have survived, that are survivors, and we're doing much better with outcomes, but that the quality of life is also equally important. And we want to make sure and give space for that for each woman. So when we think about the different parts of this, the physical effects, hormonal effects, the fatigue and pain, the nerve damage, and also the lymphedema. When we think about this is how patients report the effect that estrogen and the lack of estrogen has on the vagina. And as I said, this might happen because someone's had either ovarian surgery, they're being treated with chemotherapy, pelvic radiation, the aromatase inhibitors, the SERMs. All of these things impact and result in this low estrogen state, which leaves women talking about, when they're talking about their vulva and the vagina, they're talking about dryness, itching, irritation, burning, and dyspareunia, or painful sex. And then even the urinary symptoms, which we forget sometimes, the urgency, the frequency, getting up during the night, burning, the incontinence, and the recurrent UTIs. And we as clinicians are seeing what the changes that are happening on the skin. And I think there is a slide that kind of shows this, the atrophy in slide A, that women are having the pale, dry, shiny skin. And then in B, you can see the clitoris and how it's kind of reduced in size. And then in C, I think it's particularly important when we think about the pain women have, that the opening to the vagina becomes narrowed and the vagina itself becomes shorter, which can cause, for penetrating sex, can cause a great deal of discomfort. And then finally in D, one is looking through the speculum and seeing what we would call the landmarks. The vagina is one of the few places we are all very happy to have wrinkles that allow for some elasticity. But with the treatments that we're going through, women tend to thin out here, and the wrinkles or rugae go away, which kind of narrow that space and decrease its flexibility. And it's not just the decrease in estrogen, but also radiation therapy alone, which can kind of affect estrogen, but it can also cause just vaginal itching, burning, dryness. And while most of that is temporary, there's some types of the treatments can have very long-term effects because of the fibrosis that goes with radiation, which can cause that scarring that happens within the vagina, and over time can lead to stenosis, which is that change in length and width that can lead to pain and sexual dysfunction and just poor quality of life. So again, we're talking about loss of elasticity, shortening of the vaginal wall, narrowing of the opening, the introitus, loss of the vaginal rugae, that's the loss of the wrinkles, diminished blood flow to the vagina, and thinning of the vaginal tissue. And when I say, you can see up there, it says GSM, genitourinary syndrome of menopause, but those are just that group of things that make up this kind of phenomenon that women are experiencing. And so what are some of the non-hormonal treatments that women can use? And as you know, through this series, we've been able to go in depth on some of those things, but just kind of very briefly, we talk about moisturizers, which are different from lubricants. Lubricants are for, the actual act of sex, and moisturizers are for kind of almost like a daily, keeping the fluid and the moisture at the vagina. And so it's almost like I tell people it's like lotion for the vagina, and you put it just on the inside. And also there's pelvic floor physical therapy, which we have here, which we're helping women to both, they may be using the dilators that you use on the screen. They may be giving you some help with like kind of Kegel exercises, but they can address some of the big concerns that women have. We talked about the vaginal dilators, which are used sometimes because of the scarring from radiation, sometimes because of the narrowing from loss of estrogen. This can help with kind of preparing the vagina for penetration. And we also know just regular stimulation, which a pelvic floor therapist can help with, penetrating sexual activity, and then just using things even like topical lidocaine for pain reduction to allow for penetrating sex. And something, the fractional laser, which is somewhat controversial right now, but hopefully they're looking into studies that can help with that. But this is one of the non-hormonal ways that we can rejuvenate the tissue. And then there's a lot, and I just remind people, this is, if you are someone who cannot use any estrogen for some reason, there are water-based, silicone-based, oil-based lubricants and moisturizers. And then there are the hormonal treatments that one can use for women with moderate to severe. And this is for those women who don't respond to lubricants and moisturizers. And I tell patients that this is incredibly important because I think that sense that there is nothing for me. And there are many studies that address the safety of vaginal estrogen for women, even with a history of breast cancer. And so this low dose vaginal estrogen, you can talk to your provider about whether that would be appropriate for you. And hopefully they've seen some of the studies that support this. And so for that, there's also DHEA. There's one vaginal suppository here, prosterone, that women use for this. It's been FDA approved, and it's for severe dyspareunia. And so we do use this for some women, and this is also an option you could share with the provider. And then there's selective estrogen agonist antagonists that have been used for painful sex. And I think a lot of providers have less familiarity with this one, but I think it is a topic that you could approach with them, and it shows, because if you look down there, it says anti-estrogenic effects on the breast, but not approved for women with breast cancer. So still they need to, if someone who knows what this is can better kind of tailor this to your use, but favorable effects on the bones. And this is important for those women who are losing estrogen very early in their lives. And then I think the one that causes the most kind of controversy and concern is testosterone therapy. And so we are mostly not, we're not using testosterone therapy for the kind of as much the vaginal, but more for as the hyperactive sexual desire that we'll talk about a little later. But my biggest part of this is that if you look at all of the concerns that we talked about on the top row and that tissue, and looking at all these patients after they've had treatment and looking at the great improvement that has occurred with these kind of treatments. And I think this is incredibly important and reassuring that no matter who you are, there is something out there to help. And then there's the emotional and kind of psychological effects of a cancer on sexual wellness, body image concerns, depression and anxiety, and fear and trauma. In addition, it's also the relationship and communication challenges, partner dynamics, loss of desire and intimacy. And I think that, as a GYN, they've prepared us somewhat for all of the kind of medicines that you can use. And I think that the concerns and the limitations kind of rear their heads when we get to these things where it's not as like clear what are the options for these for you. And there are kind of 4 areas in which the change in sexual desire, like decreased sexual desire, decreased ability to become aroused, and not always that women lose their orgasm, but their orgasms are dampened. They don't experience them as robustly as they did before. And then the pain of actually having sex. All of these things can occur either individually or they overlap, and they can change one's desire for sex. And there are some treatments for hypoactive sexual desire. Addie is probably the one we use most commonly, and it has studies of use in women with cancer. And it helps to increase like actual sexual events as well as arousal. It is recommended that one have no more than 2 drinks if they're having it, and you need to wait 2 hours after drinks. And because those side effects are kind of dizziness, somnolence, and fatigue. One that's used, and Addie's been out for almost 10 years now. Vyleesi has a little more less time out, but it's used a lot less often. It is a sub-Q shot that one would take about 45 minutes before desiring to have sex. It does have some people who shouldn't use it, those with uncontrolled hypertension or cardiovascular disease. And because its side effects are nausea, vomiting, flushing, and headache. And it's my experience that the headache can sometimes be quite, it can really present a challenge for women. And again, this is where we get into testosterone. Now, recently there are no kind of FDA approved testosterone for women. And so we have been using either 10% of the dose that we use for men or resorting to compounded elements. And depending on where you are, that may or may not be something that's allowed in your system. In addition, Wellbutrin can, even though this is not its FDA approved use, it can sometimes help in those women who've lost their desire because of SSRIs like Prozac, Zoloft, but also in and of itself, it can help with those who've lost the ability to orgasm. And it does seem in a small group of women to help with just hypoactive desire disorder on its own. But also, and I think they've talked about this multiple times throughout this series is the importance of intimacy. An inherent part of sexuality that includes both physical and emotional components. And I think it's not synonymous with sexual activity. And that's important because for some women for whom sexual intercourse is no longer possible, we really strive to increase and to allow for other ways to be intimate with their partner. And there have been papers and studies written about the fact that women and men who are unable to have sex any longer, they can adapt sexually to their cancers without having to navigate through sexual intercourse. And I think that's really important. I think Life with Cancer is just an amazing center that allows for so many ways to try to address the kind of intentional intimacy, well before penetration, well before any sexual act, but helping couples to kind of navigate this space. Both with couples therapy, behavioral therapy, support groups, and the medicines that we talked about before. And there's many titles and kind of diagnoses, codes for what women are experiencing, but it all kind of ends with decreased desire and arousal, pain, and changes in the way or the opportunity for orgasm. And so, but I think by doing this and making sure that we understand this is as much a medical problem as cancer itself is, it allows for women to seek care in evidence-based ways in places where they can be safe. And we are specific to the diagnosis, making sure that we are treating them in ways that ensure or try to achieve success for them. And then for many women, the effective hormone therapy on sexual function is one of the things that we talk a lot about. And so there's right now, and I think I'm saying this because I think there will be some questions about it. We're unsure whether getting estrogen or progesterone will change how one experiences the kind of libido issues, but we do feel very comfortable about how it affects vaginal dryness, dyspareunia, which is the painful sex, and hot flashes. The relation factors in physical and mental health are things that, as I said, we can address with behavioral counseling, with couples therapy, and then we also, one of the things we talk about is that, of course, if you're not sleeping, if you're bothered by hot flashes, all of those things, that fatigue also has an impact on sexual function. So we work really hard on trying to address all of the symptoms that may be impacting a woman as she walks through this journey, so that we are then able to impact her sexual function. And so we're located in the Inova Seville Cancer Screening and Prevention Center, which is in the same kind of building as the Life with Cancer. And we invite anyone to reach out. We have a sexual wellness clinic on Friday mornings, the first Friday of each month. And in that center, you have the opportunity to meet with both a sexual therapist, a pelvic floor therapist, and a gynecologist to address the multifocal issue that is sexual wellness. And I am open for questions.
Thank you.
Thank you.
Let's see here. I know there's so much to cover and such a short amount of time here. In the chat here, questions tonight. I know it's got to be something out there. I know the questions about Addie have come up in some of our groups before too. I'm not getting a clear picture, at least from here, a medical point of view here. How much are they getting prescribed and how much are they being talked about with providers? I know sort of they carry this whole host of side effects, but they're effective when used, but when they're stopped, the effectiveness is being lost. So there's a lot of questions because I don't think a lot of our women out there have a lot of information on that.
So I think that we use Addie quite a bit, and the majority of women, it can take up to 8 weeks. So it is like, you're locking in and saying, I'm willing to kind of make this effort. And so I encourage women to say, okay, I want to plan. So I say, it could be 8 weeks. We're going to give you a prescription for 12 weeks and let's see how it goes. Check in after a month if it's not working, but recognize that, it may take that amount of time. And I will say, of the women, I would say probably 80% of them get some effect. I probably had maybe 1 or 2 who've had no effect, and some people who they didn't know if it was worth taking it every day. But the majority of women do feel that it is very helpful, and they notice that maybe they are having sex once a month, and now they're having sex 2 to 3 times a month, which is a significant change for them.
Oh, for sure. And you're seeing this, prescribing it for low desire. What are the
Right. So
things
I
you're
think
most
it's
prescribing it for?
so usually for low desire, and like this lack of arousal. I think many women notice that it just feels different, right? It just doesn't feel the way it did before they either had, risk reduction surgery or they had cancer. But and I also explained to them, and I think it's important to say this here tonight, that for those women, this is actually FDA approved for premenopausal women, but there are actually studies already of breast and have been completed that demonstrate that this is also helpful in postmenopausal women. And that is really the majority of people that we are prescribing it for, in part because even for our age-wise would have been premenopausal because of their journey through cancer, they are now, menopausal. And so we're finding that it's very helpful for them. We're prescribing it. Yeah.
And do you feel like I'm happy you're prescribing it? Do you feel like there's a lack of provider knowledge? I don't know if it's oncologist, gynecologist, who is best supporting
So
patients have questions about this and know that there's something out there, and that side effect management of that. And are you also prescribing therapy or some supportive services in addition to that? How might somebody approach it with their physician?
So I think, just mentioning it to your physician, and I think GYN gynecologists are the right group of people to discuss this with. And I think, coming in with the knowledge that I understand that this is for postmenopausal women approved, but I've read there are studies, and and I understand I'm doing it off label, but I would like to try it. And 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 just being, making them comfortable with the fact that you're aware, because I think they're very comfortable. It's simple. You write, it's once a day, once a night, and so people are really okay. But I think you would probably have to bring it up, because I don't think it's something that was taught in medical school or residency.
Yeah, or nursing too. And I
Yes,
appreciate
yes,
that. And certainly if there's something they could take from this program, it's okay to bring it up. Um,
yes, I think absolutely.
yeah, certainly. I've been asked by providers about it too, so that makes me think, even as a
Mhm.
nurse in this field, that there's a lot to learn. So
Yeah,
it's
absolutely.
fantastic. We have a bunch of questions in the chat and the Q&A. I'll start. How do we best approach our oncologists for different types of therapies? I know you touched base on that, but maybe just expanding a little bit on that, on how do you ask about what's available and where to go?
So I think if you're still in the oncology space, then sharing with them that I've seen something and I've learned a little bit about vaginal estrogen and other options, and I would like to just see, I know there are moisturizers, I know there are lubricants, and my spouse and I have already tried these things. We'd like to kind of look at vaginal estrogen. I want to know how you feel about it, and if you're familiar with someone who could prescribe it. And our approach is always to do this as part of a team. So I always secure chat the oncologist and I say, I saw your patient today. I think she's a good candidate for this. I want to make sure you're also comfortable. And so far I've gotten great feedback. All of them feel pretty comfortable, as long as the gynecologists are writing it. And so we move forward with that. But I think you can bring it up to your provider and say, I heard this was comfortable, that this is okay for me, and I want to make sure you're comfortable with me using it. And I think doing it that way makes the oncologist feel better about saying it's okay. You know, they don't necessarily want you to come and say, I want to take it, give it to me. And I don't think anyone really does that. But when you just say, I've heard about it and I'd like to see if you feel it's okay for me in my particular journey, then I think it works out well.
I like that, and I think that's I think it makes it easy, I think, on individual out there being able to present it. I heard something.
Yeah.
Is this
Mhm.
something that's right for me? Can we talk a little bit more about it? So that
Right.
just simple and easy, for about a variety of things.
Right.
Um, Another question, who prescribes medications to help with arousal? And I know we touched OBGYN, a urogynecologist, all of the above. I don't know if any expansion on how you talked about that.
I would say it's probably the gynecologists who do the ones for arousal. And so, and as I said, I think most people are getting comfortable with Addyi. I think fewer people are comfortable with Vyleesi. And I think there are a host of newer clinics in the area that are comfortable with testosterone.
Okay, and that's great. I don't think that's something we've talked about, even some of our programs, is about the testosterone piece, but thank you for
And I,
bringing that up.
and I think that's a one that, like I said, is pretty controversial for where we are in this space, because there are not really good studies about testosterone and say like breast cancer. So for that particular piece, you really do have to talk with your oncologist, and they may not be there yet for that population. But we're talking about women in all cancers, and there are some women who would still need this, and that may not be a bigger concern for them.
Okay.
But there are good studies about the kind of testosterone and sexual arousal and that piece, and particularly for even for vaginal testosterone.
Okay. Oh, that's great. That's something we need to explore more for sure. Um, someone writes in, how long do you need to stay on vaginal estrogen? Does it stop working when you stop? She also said, I've been using vaginal estrogen and it makes me very bloated. Is there something I can do to help stop this other than not using the vaginal estrogen?
So, speaking in more broad terms, what I would do is actually most of the ones in the studies where we looked at it for people who've had, some kind of estrogen receptor cancer, they use a very low dose. And I recommend that patients, they're doing kind of the twice a week. And then I would say just drop it down to once a week and see if that makes a difference. And it is true that when you're not using it, it doesn't continue to work. But for many women, it's improved their tissue enough that then vaginal moisturizers and lubrication are enough and sufficient for sex without pain. And so that's what I would do, is just kind of drop it down a little bit.
Okay, and then work up the non-estrogen moisturizer lubricant
Components, right?
and see if that's making a difference with a little bit of the estrogen. Okay, great. And the bloating, again, you're saying to drop it down to manage side
Yeah,
effects
and see if that makes, I don't see that as often.
Okay.
And so I would see what dose you're using, because there are actually more than one dose of vaginal estrogen, even without just doing it more days. They're higher dose, and I would try to drop it to one of the very low dose estrogen, vaginal estrogen combinations.
Okay, so great. Maybe asking about dosages and see where you're at, and if there's modification that's possible.
And if that doesn't work, then maybe moving to some of the non-estrogens, the DHEA, or depending on what you're using it for, but using like the intrarosa, that kind of thing instead.
And again, we haven't talked a lot about that. Could you just expand on that? I know you touched base on that.
Yeah.
When certain ones might be used, and what you're seeing as results of each of those?
So I would say the ones people are probably most comfortable with are the vaginal estrogen, and then the intrarosa or prasterone, which is a daily. And that one is very specifically for painful sex, right? And so I think, women feel, people are starting to feel more comfortable with it. It was in one of the studies, at least, that looked at kind of women with breast cancer, but, doesn't have as much data behind it because it's a newer product. But that is one of the others that you could use.
Okay, great. Someone writes in, I'm in treatment for breast cancer, currently taking an AI after hysterectomy for endometrial cancer cells caused by tamoxifen. I know that vaginal estrogen can help with dryness. Would you please address the most recent studies that say vaginal estrogen's okay? I still feel nervous, but want to try it.
Okay. So there are a few studies, and when you say you said endometrial cancer cells.
This is in the chat. Currently taking AI after hysterectomy for endometrial cancer cells caused by tamoxifen. I don't know if it's a
Yeah. So,
sensitive.
and I want, and I say, we say, and Rebecca said this earlier, this, we're not very specific in this because, from the questions, I can't really tell the entirety of your medical history in order to give a really appropriate answer. But I would say that there are studies out there where what they did was they looked at the lowest dose kind of estrogen products and they took a variety of tests of research studies, put them together. And in most of these studies, they are looking at what is the level of estrogen tested, in the blood when someone is taking this. And I always remind patients that, the general is to take it for 14 days straight and then the twice weekly. The 14 days, they did many times see that women's levels went above postmenopausal. However, in those kind of twice weekly days, most people did their levels stay below the menopausal range. And that's important because for some patients who are at higher risk, I would say don't do the 2 weeks because it will make their oncologist quite uncomfortable, and then just do the twice weekly. You'll get the same place, but it may just take you a little longer to get there. And so and for many patients, that makes them feel more comfortable also. For you with the tamoxifen, vaginal estrogen would help with dryness. I'm just not sure about the endometrial cancer cells that you're talking about
Just
now.
put another little update. It says endometrial cancer was just a rare side effect. I was a small percentage. Oncologist says the estrogen's okay.
Yeah, because I'm just not sure, but I would say for most people, unless it's endometrial, you would do fine because the effect on the uterus is very small. Let's see, which drug
are you, which drug are you talking about that also works for postmenopausal women? She missed that.
So I think you're talking about Addyi, because we're saying both Addyi and Vyleesi were approved by the FDA for premenopausal women, but a lot of what we are using it in postmenopausal women. And there are studies that actually looked at it in postmenopausal women, but they did not seek FDA approval for that. And so they still work, and they work quite well in postmenopausal women. So I don't think you have to be frightened of that. And you have to just let your doctor know, I'm aware, I read, and I'm comfortable with that, and they can document that. But it is Addyi and Vyleesi are the two drugs.
Okay. And I'll get your slides out later to the group. I'll make sure you get the slides. So all these medications and names will be listed on there for you. So I said, this is helpful. Curious to know how Addyi interacts with estrogen blockers such as tamoxifen.
So because Addyi is working more at the neurotransmitters, so it is looking at, decreasing serotonin and increasing your norepinephrine and dopamine, which help with arousal. So we generally don't see the problem with tamoxifen here. I think you're muted right now, Rebecca.
Sorry. A provider perspective with vaginal estrogen, is there something to the sponge theory that when you first start using estrogen, your vagina or pelvis soak up the estrogen, possibly increasing your risk of systemic estrogen? Just something that I've heard, wondering your thoughts.
And I think that's actually the whole thing about the 2 weeks, because you're using the 2 weeks at the time when your vagina is at its most likely to have fish like cuts and thinning. And so that's the time when you're most likely to get above the menopausal level. So I think you're exactly right. That is true. And that's why for many women, I would just say, while it may take a little longer, I would just start with the twice weekly and not use the every day for 2 weeks.
Okay, that's helpful. Thank you. That's helpful to me too. Someone writes in, I'm coming up on 10 years of Aromasin, not sure of efficacy after 10 years. Is there evidence of improvement in sexual function when stopping an AI?
So in a sense that if that is when your kind of sexual dysfunction started, yes, absolutely. But, for many women, depending on kind of timing, we finish our treatment and then we're in menopause, and that brings its own kind of concern, kind of dysfunction and sexual um, concerns. So you may get better from the AI, but have to deal with other kind of menopausal related sexual concerns and issues.
What about the use of cannabis? Any information on that?
So I would be honest and say I don't have a lot of information on it. I think, my reading in this area is that it is helpful for some people. I think we had a period where we were using THC and other kind of oils and stuff, and that hasn't been supported. But the use of cannabis in kind of the oncology field has long been supported and found to be useful.
Uh,
Can
and can primary care physicians or PAs prescribe Addie? Anybody, as
I
long as they're
believe that is
comfortable.
absolutely true. Yes, that they could.
So that's great if someone's really comfortable with the provider,
Mhm. And I think there are probably more PAs who are quite comfortable prescribing Addie.
That's a good point. Um, are there
Not-
natural or homeopathic options we haven't talked about?
So I think there are many natural and homeopathic options out there. The question is, what's the evidence for their efficacy? And and I actually do try to read and figure this out, and I don't see a lot of good studies around this. So, people are using many things, and I just, I'm unfortunately I can't tell you whether or not they're better than placebo when you look at maybe for one person, but when you really look at a large group of women, whether those really make a difference.
Thank you. I know that there's a lot that we say that too. There's so
Yeah.
so much to read
Yeah.
about, but not always the evidence to support it. I will type the Addie and Velisi into the chat so you can see the proper spelling of it. Again, I'll send you out those slides. Someone's asking about letrozole, and I maybe Addie is what they're talking about. Addie,
Yes.
but with letrozole, any
Right, and it has been. And then what I would say, I want to just point out about letrozole, and this is something that when you're bringing it to your oncologist, you do want to bring up because the AIs, because of how they protect against estrogen, it's a little bit different than like tamoxifen. And so there's some fear, and there's actually even in the studies, they do point out that the protection is not as much. With tamoxifen, you're kind of blocking more broadly, and with letrozole, and you're blocking just a specific kind. And so you do have to be a little bit careful. But so far, it has looked good, and the oncologists have been comfortable with the AIs along with vaginal estrogen. And this is very specifically for vaginal estrogen, not a problem for Addie and Felice.
Okay, so I'm just ready for cannabis. I've had some patients use it to help with arousal.
Yes.
Foria is something I've recommended for patients.
And I've definitely had them use cannabis for arousal with some.
We're going to tap into that a little bit later, but certainly I can bring that up to Lauren to see if that's something we can talk about a little in one of our additional programs as well.
Right.
Does hyaluronic acid lubricant work as well as vaginal estrogen for atrophy?
So I would say no. Hyaluronic acid, and it's a part of many of the moisturizer. Does it work as well as vaginal estrogen? Probably not, but because it's not going to kind of reverse atrophy. But what it will do is bring moisture, and that moisture, and retain moisture, and that moisture may be enough to make you comfortable exercising, having sex, urinating without pain, all of those things. And if that's really the goal, then that's sufficient. So it's not as much to kind of reverse atrophy as it is to make us comfortable doing those things that atrophy has made us uncomfortable doing.
Are there any cases of serotonin syndrome when those drugs are used when on anti-anxiety meds and stimulant meds for ADHD?
So I haven't seen it with the stimulants, but I'm very careful with women who are actually on the SSRIs if we're using these drugs.
Can you talk a
I
little
don't
bit about the
And I
big
don't
side
see
effects?
the serotonin syndrome, but it's just because of how they interact and how they're decreasing. I am pretty, just being very careful and not necessarily using Addie in those situations.
With SSRIs as well,
Mhm,
right? Yeah,
mhm.
okay.
Yes,
And
yes.
I know that's can be a commonplace in many of our
Right.
patients.
And that's always that tension between using like Effexor, for which many women with cancer are using for their hot flashes, and then needing like Addie. So we do, then, a large part of what I do is spending in that time of recognizing that besides SSRIs, there are also gabapentin and there's Veoza, and there are lots of other drugs, oxybutynin, that affect the hot flashes so that we can get a little more room for where we have fewer drugs, such as Addie and vitamin C.
I know that's come up for the Veoza. That's used for hot flashes.
Hot flashes and night sweats, yes.
And what is the effectiveness that you've seen in your practice with that?
So I think that it's been really effective, I think, for sure. But the concern with Veoza in a very small group of women, they did see this kind of transient transaminitis where so for patients, they're getting their liver function tests are increasing and increasing to a significant amount. So if we have to watch them quite carefully, and then if we see them increasing, we actually stop the drug. So I've not had any patient we had to stop it on, but but it is kind of sometimes inconvenient to have to get your blood drawn. So I try to, write them ahead, so that they're doing it, and then we can just call and see if it's okay to continue. But the drug itself really does work. There is a paradoxical effect where occasionally it can make you have hot flashes, but that's extremely rare. But
Um, where can I get information in exploring natural possibilities?
I would say they're integrative medicine centers, and those are usually where they are experts on kind of the natural possibilities for for drugs who would approach to which work for things like sexual dysfunction.
Okay. Um, is low dose estrogen Vagifem safe for HER2 positive breast cancer survivors on an AI and postmenopausal?
So this is where that particular small group of people, and first of all, you have to talk to your very specific oncologist. And then secondly, the vaginal estrogen, because you're using an AI, which is really, it's helping the fat cells in our body not to turn into estrogen, to not to turn the androgens into estrogen, that this is where they start to worry because it's not protecting everywhere. And so they want to be a little careful for those patients. However, I will say the large majority of oncologists are comfortable with this combination in postmenopausal women.
Okay, great. My vaginal tissues are still very sore, even when using vaginal estrogen for more than a year, 2 times per week. Thoughts on
So,
that?
and so I think a couple of things I don't know without examination, but one, I would look to see if there are any other contributing factors. Then I would think about maybe switching from the vaginal estrogen, like we said, to something like Intrarosa or Prasterone to see if that would be more helpful. And then I would also check in to see if you're using the moisturizers in addition to the vaginal estrogen, so that you're having kind of a constant group of medicines that are approaching and trying to treat this soreness.
And thanks for bringing that up again. So again, even if you're using that vaginal estrogen, continue to use those non-hormonal moisturizers on a regular basis too. That really can help with that.
I really do think that that's kind of the best. And I tell patients there's so many options out there. There's a list that's just, I mean, a number of them. And I would just find the one that works for you, because not everyone works for everyone, for each person. But just it's not like when we were 25 and you could just kind of hop up and have sex. It takes some planning and some intention to be prepared for an interaction that's not painful.
Thanks. And I think so many women are interested in asking about if they're candidates, or can they take that vaginal estrogen. I'm wondering, are they just forgetting about the non-estrogen moisturizers because
Yes.
maybe they were told it's okay to use this other one, so you're not using the ordinary non-estrogen ones.
And I do think, because right now in this country, everything is about estrogen, and there's a lot about menopause, and it's about estrogen, and so it's hard to be like, well, I'm gonna try the moisturizer. I just want to go right to the top and use the estrogen. But I do think that it's not necessarily just estrogen, and it's also not necessarily that you'll need estrogen. There are women for whom a moisturizer and a lubricant is perfectly fine, and they have satisfying interactions without pain.
That's great. I'm going to be more cognizant of that too, and asking that question.
Yeah.
Someone writes, post-menopausal and taking Ibrance, what's safe to take? Sort of a broad question. Oh, with anastrozole. What's safe to take with anastrozole? I mean,
So
again, coming back to
again, it's the same. It's the same as the aromatase inhibitors there. So, yeah. So I think these are the things where you're talking about same thing: moisturizers, lubricants, but most importantly, talking with your oncologist and your GYN if they can chat and see if they're comfortable with you adding a vaginal estrogen if the first two are not sufficient for you.
And I also like the fact, I know you started with that, you make it easy on your patients. You'll send a chat through to the physician.
Mm-hmm.
And I think just giving that guidance, like you'll take it from them, and let me help make this easier. I think
Right.
that if you can bring it up, and
right. And so I just secured, we are allowed, because we're sharing the same system, to just kind of ask them. And I say, I saw this patient, what do you think? But I think the oncologists do a great job at ANOVA of writing. If they think it's okay and they know they're sending them, they'll say, and I think she is a candidate for vaginal estrogen. So it makes it so much easier for the patient in those situations.
that's great. I like that. I like that communication's opening like that.
No, absolutely.
Because it wasn't always like that. It was
Yes.
us asking.
Yeah. And I think, for women who are in this situation, we talked about it, try to just point out how important it is: the behavioral therapy, the sexual therapy, the pelvic floor, the oncologist, the, estrogen, all of those things together can get women to, I'm a strong believer that I have not met a woman that we can't get to a situation where they are improved enough to have a good sexual experience. What moisturizer do you recommend?
Oh yeah.
I would never be guilty of trying to pick one or the other, but I do. I mean, there's just the list. I mean, there's so many brands. Obviously, Reverie, Replens. Oh, yes, Kendra, gynecologist. I mean, it just goes on and on. So, and you can literally, I never say this, but you can literally Google and say, what are the top, and they will run them across and their prices. But if you call Seville, we also keep a list of what the ACOG, which is kind of the guiding body for OBGYN, their list for women with cancer, and we can share that list with you also. And I can maybe put it share it with you guys, and you can include it as part of that.
Perfect. That would be
great. Because we keep that both for moisturizers and lubricants.
Okay. I know we have a list too. I would love to see what you have. That's great.
Yeah.
And we certainly can check that
Absolutely.
out. Paul Road, Uberlube, Reverie. I mean, there's so
Yes.
your
Uberlube.
Amazon basket.
Yes, we absolutely.
And just stepping back to the woman who we answered the question for before, she's on both Ibrance and anastrozole, taking both. So wondering what is safe, again, going back to your provider.
So I will say for my patients, I always, if they're drugs that a combination I haven't seen before, I will run it through like a drug interaction before I give it to them, just to make sure. And I think that's what you need to do.
Oh, that's great. That's helpful. And I think
Yeah,
just
and they're, yeah,
additional confidence that somebody's looking at that
right, exactly.
and helpful. Take a look. I think those are all the questions. Oh, everyone wants the list. Everyone wants a list. So you want to do a little late night Amazon shopping. I mean, there's so many. Sometimes, and all different price points, just being able to
Yeah,
buy something.
absolutely. And I like that people are sharing what their own favorites are. I think it
Mhm.
mine coming from each other, probably not okay coming from us.
Oh yeah.
But yeah, no, I think these are really good. And the list includes some things that are commonly in your house, and there's, whether or not that will work for you, but there are, quite a few things.
Mhm. Oh, we've had a lot of interesting old way of thinking what works around the house.
Yes,
To get out.
absolutely. And there have been thoughts about whether those increase risk for infection or
Mhm.
not. And some of those things are part of some of the newer, like the drugs. Kendra, all those drugs have coconut oil, they have, sunflower oil, they have all these things inside of them. And so, you just have to kind of decide whether or not the process they use to produce these have made them safer for the patient.
Mhm. Mhm.
But
Well, thank you. I think if there's one last message here, so many choices. It's difficult to find one with good efficacy in general. I know all of us are different. Yeah.
one of the things I would say is if you are seeing a provider, many of them have samples in their office. And I would encourage, like when you say, hey, can you try to get more samples? And that allows you to have the opportunity to try things before buying them. And I
Mhm.
think that helps it to make it, an easier choice, because it's not one size fits all. And what may work for me may not work for you. And so I think just trying to get samples where you can.
Yeah, and Lauren and I are too trying to
Stock,
ramp
like,
up,
yeah,
and in
yeah,
the specialty shop. So we'll certainly see where we go on that, because if it's there in hand and you have some choices, I think that
right.
helps with compliance. At least helps you try when it's right
Try
there.
it. Yeah,
Uh,
absolutely.
I get
I
it.
do believe that's the case.
Good suggestion. Didn't even think of samples. Everyone loves a sample, and I don't know if you call out to some of the companies if they'd even send you some. If you sent them an email, I'm interested in your
Yeah.
product. I heard about it. Do you have some samples you can share?
I
It's
mean, that if they
non-prescription.
would do that for patients, that would be great. I mean, that's literally what we do. We reach out and we say, can you send
Yeah.
us samples? And, and we try to share them with each patient.
Sure.
But
That's it. So looks like any other questions, put it in the, if you want to put it in the chat. This was great. I love how we had a lot of time for a lot of Q&A. That was really
yes,
helpful. And a lot of questions. So we haven't talked a lot about medications for desire a lot, or just
mhm,
really focused on just having an open space to be able to talk about all this. Thank you.
yes.
Another great program.
And I just,
Wanna-
I really thank you guys at the Life with Cancer and Rebecca meeting you here, because I do think, like, I mean, this is amazing. Each and every day, I have a woman who has not had an opportunity to talk about sexual wellness in her journey with cancer, either because she wasn't comfortable, or there wasn't time, or the provider wasn't comfortable. And I think, like, just having you guys do this is such a it's amazing. And the list of things you have, like who is talking about eroticism, who's talking about toys in a way that patients can, really get an opportunity to hear about how do you use them? What are the options out there? Because, based on culture, based on religious taboos, all the different things, people may not have had an ability to do these things. So I think what you guys are doing is amazing and such a help for each of these women.
Well, we're so grateful to have you right here, which is awesome to be a part of Seville, which is sort of this next step, being able to have a space, have
Right.
providers, not only for those at an increased risk, but for those in survivorship, like sort of extending.
Right.
This is
Absolutely.
outside of the oncologist. This is life.
Yes. Yes, that is real. That's a flight.
And getting a referral to your practice or coming to be seeing your practice, what is the best way for individuals?
So,
Slide was up
you
there.
know, if you call the Seville Center for Cancer and just you get the main number and you just say, I want to see the gynecologist, and I'm the only gynecologist here right now. And I'm seeing any women, I very specifically see women who've either had cancer, have a risk for cancer, or and that risk could be either by family history or mutation. I see women with I see women with, you know, sickle cell who have risk, women who have other, you know, even ulcerative colitis because of their increased risk. So any of those women I'm able to see in this space. Oh, I love this.
Awesome.
Thank
Oh,
you.
and lots
This
of
is like,
lots of awesome comments coming in. Thank you for understanding. I love to end on this. That sex is important to women, and we need your help, especially after having cancer. I mean, firsthand compliment here. I'm a patient of Dr. Davis-Wilensky. She's awesome. Love to hear that.
thank you,
That makes it
Carol.
real.
That's very nice. Yeah,
Really
no, I
seeing
think
you.
it's so, I'm just super excited that you guys are doing this work. It's amazing.
Well, this is awesome. And thank you so much for coming and answering questions and just being in this space that so many women have decided to come to tonight, that this is
Yes,
so
thank
important.
you.
We're glad to be doing this, but another patient of yours on there. Oh, see, your patients are coming too. They know it's important. You made them feel it's important.
Yes, thank you for coming. Yes.
And that you have this space here to be able to meet with everyone who participated tonight. Again, this is recorded usually by next week. We send out an email to say with the link to say it's up on our YouTube site. Feel free to share
Oh,
it
okay.
when you want. Go back, reflect on it. I'll send out the slides. I'll send you out that list when you get it to me, and we'll follow up. Any additional
Okay.
questions that come, please feel free to reach out to Lauren and I on the email. Our next program, I'm looking here, April 1st, Dr. Sharon Bober, Managing Emotional
Oh,
Distress
wow.
Related to Sexual Health Changes.
That will be
She's
amazing.
she's awesome.
Oh, that would be an amazing program.
So thank you all for coming tonight. Thank you for this awesome presentation, Dr. Davis-Wilensky, and I appreciate it.
All right. Thank you.
Thank you all. Have a great
Have a
night.
good night.
Take care.
Bye-bye.